much for the work you're doing and for having me join you this morning. It's so impressive to have a group that wants to tackle an issue like making sure that kids get off to the best possible start in life, and in particular to think about the issue and try to advance the issue from the perspective of a child succeeding in school and learning how to read on grade level. And I was struck, Dana, as you read the Frost poem this morning, which I came to appreciate in college, how lucky we are to be able to learn Frost and appreciate those words. It's an incredibly moving poem. And don't we really want all children to be able to get to that place where they can appreciate the simplicity of walking through woods on the snowy evening? So you're here today thinking about health and thinking about the way Medicaid can help advance children's development, and that is such an amazing goal. And you're thinking about the path forward. I'm going to talk a little bit about the miles we've come to build on the Frost poem, so that you later today can think about the miles you have to go and how the Medicaid program can help. And I hope that by the end of my remarks, I've laid the groundwork for great conversations and what looks to be a really rich agenda for the day ahead. So what I'm going to talk about is the miles we've come on coverage and making sure kids have Medicaid and CHIP coverage, the miles we've come on benefits and making sure Medicaid's benefit structure is as strong as possible for children, and the miles we've come in 4 particular areas that I think align closely with your goals for today. I love that this session is called Medicaid as a Lever for Impact, because I feel like over the past 8 years of the Obama administration, that's exactly what we've been trying to do, is to exercise the lever of Medicaid to have an impact nationally, and at times with a particular focus on children. So what I want to start with is just taking a step back and thinking about the context of health in America and health coverage in America and where we stand right now that we didn't stand a few years ago. And it's driven by Medicaid expansion, it's driven by the Affordable Care Act, and it's driven by the eligibility simplifications that were a key part of ACA implementation. And so as we stand here today, the uninsurance rate for all Americans is 8.6%, the lowest rate it's been in our nation's history, and a substantial decline. And that's because 20 million people have coverage today that they didn't have in 2010 when the ACA passed. As great as that progress is, the gains for children have actually been far more remarkable. Right now, just over 95% of all children in America have health insurance, thanks to Medicaid and CHIP. And so that represents a halving of the rate of uninsurance for children in America. And if you look beneath that, you'll see that we have helped reach some of the most vulnerable children in society. We have increased access to uninsurance for Hispanic children. We have increased access to coverage for American Indian, AIN children. And we've even, if you look granular in the data, we'll see that some of the biggest gains have been for some of the most vulnerable children, children who have no parent in their household. So we've really accomplished a lot in terms of reaching these children. And it's part of a longer trajectory of progress of coverage for children. So if you look back over the past 20 years, since the CHIP program was created in 1997, there has been a concerted effort on the part of the federal government, of states, of providers, of consumer groups, of health plans to make progress in enrolling kids. And so it's a great decades-long success story. But if you looked just at the past 2 years, you would see that the rate of progress accelerated, and that the biggest gains in coverage occurred between 2013 and 2015. And why is that? It's interesting because you don't necessarily think of the Affordable Care Act as a kids program, right? Because kids before the ACA had the strongest base of coverage of any group. But what the ACA changed, it changed many things, but what helped contribute particularly to these coverage achievements for children are 2 things. First and simply, there was a broad message in the United States that almost everyone was eligible for coverage, and it eliminated a lot of the confusion in individual people's minds. Am I eligible? Am I not eligible? Should I apply? Should I not apply? People applied, and when they were eligible, they enrolled. The second thing that really has driven this progress is the availability of coverage to parents. So for a long time in our society, children were eligible for health insurance, but their parents were not. And so we've seen substantial gains in parent coverage and reductions in the rates at which low-income parents are uninsured. And that has also helped driving progress for their children, because when parents enroll, children enroll. And it's a key point to keep in mind as we think about the future and where we're going as a country and how we continue progress. But beyond enrollment, we also know that having a parent have health coverage has health benefits for the children, because the parent can stay healthy, they can work, they can go to school, and they can be present for their children. So there's a lot to appreciate and respect about the ACA's accomplishments for children. And I hope you keep that in mind today. Now, of course, we need to make sure Medicaid delivers for these kids, and it does. And I wanted to share a story of one child in Houston, Texas, and the way Medicaid delivers for her and her family. Her name is Deonk Bradley. Deonk was born with Charcot-Levin syndrome. It's a rare genetic disorder, and it produces malformations of the vertebrae and the ribs. Deonk has difficulty breathing, and she's susceptible to respiratory infections like pneumonia that can have life-threatening complications. Deonk spent the first 7 months of her life in the NICU. In just the first 4 months, her family blew right through the $3 million lifetime limit on their insurance policy, and they needed insurance coverage. And no other insurer in the United States would cover her. Only one stepped up to the plate, and that was the Medicaid program. Today, Deonk is 9. She's in 3rd grade. She has great spirit. She loves to dance. She loves to fashion, and she's a big fan of Michael Strahan. But her favorite place to be is in school with her friends. Medicaid is what makes it possible for Deonk to be at school. Medicaid covers her nursing care, her medications, her ventilator. And Medicaid makes school possible for Deonk. At the same time, Deonk's family has been kept out of bankruptcy by Medicaid. Medicaid covers her life-saving surgeries, her medications, and her physical therapy. I don't know whether Deonk and her friends in 3rd grade in Houston are reading proficient, I'll confess. But I do know that without Medicaid, she wouldn't be at school at all. As her mom told us when we called her, without Medicaid, my child wouldn't be alive. Deonk's story is just one of the millions of examples of the way that Medicaid is making a difference in the lives for children. And if you take a step back, it really corroborates a larger body of research literature that shows that when children have Medicaid or CHIP coverage early in their lives, it has a lifelong impact on them. It helps them stay in school, it helps them graduate from school, and they go on to earn higher wages and be healthier as adults. Over the past 8 years, we've really tried to dedicate ourselves to making our coverage as strong as possible for kids like Deonk and the other 33 million children who are touched by the Medicaid program at some point in the year. One reason that Medicaid is so important to children and meets their needs so well is summed up in a very complex acronym, EPSDT. It stands for the Early and Periodic Screening, Diagnostic, and Testing Program. It is not a phrase that rolls off the tongue. But it's interesting because you hear a lot. There's been a lot of buzzword as we at CMS and states and providers have worked on delivery system reform. And you hear people talk about, let's get a patient the right services in the right setting at the right time at the right place. And that's basically what EPSDT does. It is widely regarded as the gold standard in benefit design because it so closely meets children's needs. And for a child like Deonk, it is what underpins the comprehensive services that she gets. It's also the main lever I will expect you all to be pulling as you try to make sure that Medicaid has impact for kids and helps them stay in school. Under EPSDT, states are required to provide comprehensive services to children and to cover all of the services that are appropriate, medically necessary, and that help correct and ameliorate medical conditions, which means that EPSDT not just promotes a child's health, but their healthy development. Over the past few years, we've been trying to help states identify specific approaches that help advance the goals of EPSDT. And if you go to our website, medicaid.gov, you'll see there's a guide there on how to move EPSDT forward and the different strategies you could take. I should also take this moment, since we're talking about medicaid.gov, to mention that Medicaid is now for the first time on Twitter, and so you can follow us at medicaid.gov. We've also done a lot of work in EPSDT of making sure our data is stronger so that we can measure and monitor the extent to which children are getting services so that we know what the effectiveness of EPSDT is. So EPSDT has a couple of particular relevancies to this group. One is it helps make sure that health problems and developmental problems for children are identified and assessed early in their lives. And of course, the sooner you diagnose a problem, the easier it is to address and treat it. One way that we can address issues early is by making sure children have screenings. Whether it's physical, mental, developmental, screenings underpin EPSDT and also underpin our ability as a society to apprehend health and developmental issues in children at an early age. And then the rest of EPSDT's benefit is what helps back it up, because when a health condition is identified pursuant to a screening, the child is connected with the services they need. To make Medicaid coverage as strong as possible for children, we have, over the past several years, found a number of ways and a number of targeted areas in which Medicaid could more clearly support children's development. And so I wanted to mention 4 of them to you this morning. One is Medicaid's support of maternal depression and addressing maternal depression. Last spring, we issued guidance that enables Medicaid to cover screenings for moms, generally when they're present with a child as part of a well-child exam, so that a pediatrician or another provider can identify maternal depression in a mother. It was interesting to me, looking at the slides Ralph presented, how much you have an appropriate focus on the parents and how much the campaign seems to recognize that the health of the mother and the well-being of the mother really contributes to the brain development and the health and the well-being of the child. And that's why we felt it was important for us to really make sure that we were doing what we could as a program to address the health of parents. Another area in which we've done that is promoting home visiting. We've seen clearly through the work that the Health Resources and Services Administration has done over the past 6 to 8 years, the impact that home visiting to newborn mothers can have on families and children. And that's why we released guidance in partnership with HRSA, identifying ways that states can promote home visiting programs for low-income children. And home visiting can really be a central part of helping a new family get off to a successful start. We know it keeps moms and their babies well connected in their early years, and that the benefits of home visiting go well beyond promoting health. It encourages positive parenting, reduces abuse and neglect, and of course promotes readiness of children to be in school. Another key area for us, which I know you'll be talking about later today, is oral health. Kids need to have strong oral health in order to grow and to develop and stay healthy and stay in school. And EPSDT is a powerful tool for promoting oral health for children and adolescents. Tooth decay, as you know, it remains the single most common chronic disease among children and can affect all areas of a children's life. We've made a lot of gains in promoting access to oral health care. In 2000, only 30%, less than 1 in 3 children in Medicaid and CHIP got a preventive screen for oral health after age 1, and that number was clearly too low. In 2015, through concerted efforts on the parts of us, on the parts of the provider community, on the parts of states, we had moved that number up to 50%. So great progress, but also clearly not enough progress and more to do. And that is why we rebooted our oral health initiative earlier this year to Oral Health 2.0, and are working really closely with states on trying to develop stronger approaches to oral health. And I think you'll see in the coming months from CMS through an innovation accelerator program we have to help promote delivery system reform at the state level, a particular focus on oral health, so that we can develop better payment strategies and care delivery approaches to promote the well-being of children in oral health. The last area I wanted to mention is schools. It was clear to us that we needed to do more to help foster partnerships between Medicaid programs and schools. And historically, that had been hard to do because our rules had required that schools couldn't bill Medicaid unless they also billed for uninsured children as well. And that was too high a hurdle for schools to overcome. So we simplified the rules about a year and a half ago so that schools can bill the Medicaid program more easily, so that if a school wants to support services like asthma or vision screening, they can be reimbursed by Medicaid. So this is a new opportunity for states, and one we'd like to see more schools and states move forward with. It is hard ground level work to implement this policy because it requires states and schools to collaborate at the ground level and for schools to become Medicaid providers. But I think it's an incredibly fruitful avenue for the campaign to work on, and as you go home to your states and communities, to try to develop stronger partnerships at the state level and help schools develop the infrastructure and approaches to be Medicaid providers, so that to really maximize the ability for Medicaid to support kids directly in the schools, which we know is a great place to find and reach them. So I said I would mention 4 areas, but I lied. I'm actually going to mention one more, which is a 5th area in which we have not yet released guidance, but we are about to in the next couple of days, and that's in the area of lead screening. It became very clear to us after the very difficult events in Flint, Michigan earlier this year that lead screening had not been as high on our agenda or on the nation's agenda as it should have been. And as we saw focused on the health impacts of children in Flint, we realized that we needed to do a little bit more to help focus on the area of lead screening. So we're about to release guidance that talks about the importance of lead screening, that identifies some strategies for lead screening so that we can move forward with really connecting kids to lead screening services. And then following on that, as we did in Flint, making sure that when kids have identified lead exposure, that we connect them to health services through Medicaid so they can get the health and developmental services they need. So that will be our next big step forward for children. I am going to look forward to hearing, and I hope you all feel free to reach out and share the learnings from your conversations today, because I expect that as you have your conversations this morning and into the afternoon in your solution sessions, that you will come up with additional ways that the Medicaid program can support your objectives. And I hope that you always find me and my team at CMS an open partner to identifying ways to advance progress further. So thank you for having me. Do we have time for questions? Yeah.
Thank you so much for the framing for the day about how we can use Medicaid really as a lever for impact as we address these early determinants of school success. So we have a little bit of time for a couple of questions if the audience has any. Yes, please.
I'm sorry. On lead screening, I'm aware that the regulations are essentially screening the kids either very early or then they're able to wait quite long if they haven't done it. So there's a big gap allowed for a number of children. is there any way to close that in regulation at this point? It's probably too late in this administration to do it, but what are we doing about that? Because the states can go either way.
I think our guidance requires 12 and 24 months screening, but I'll have to go back and check. Is your concern that that's too early in life and not that there should be subsequent screening?
No, regularly what's been happening is that they're either screened early as you'd want them to be.
Right.
But then if they don't screen early, there's been no stick, I guess.
No follow-up
to get them
to make sure that they get screened later if they haven't been screened early. That's a very good question. Let me go back and check and see and make sure that we're addressing that issue as we promote our lead screening guidance. Like what happens after the required period if someone hasn't been screened. We'll find a way to get that information back to this group.
I just, the area of focus that you mentioned about, Hi. I'm just interested in the area of focus that you mentioned about schools being able to do more health services. I think that's very relevant to this group in particular. And I know that has to do with the change of the free care ruling that you mentioned. What's the sort of rollout plan to help states move that opportunity to practice? I know it's quite complex. It has to be sort of state regulations have to be changed. Are people coming together, or are you encouraging those kinds of groups to kind of have that conversation to actually implement the opportunity down at the local level?
We did a fair amount of encouragement after the policy was released at the federal level in partnership with the Department of Education, which, as you'd imagine, is very supportive of the objectives. I think it's worth thinking about kind of what do we need to do to kind of reboot efforts at the state level. For me, the ideal would be if we could find a couple of localities in which states and local school districts have been able to implement the policy and have them identify how they did it and best practices. I think that would help accelerate progress immensely. Because it is a challenge, and there are administrative obstacles to be overcome in order to get the policy working well.
And do health insurance plans need to sort of support this? I mean, so much of healthcare is now, you have your primary care provider, that person or center is responsible for the broad range of services, but now you're given the opportunity to really go outside of the medical home to provide those services. And I don't know how insurers are going to think about that.
Right. We don't have requirements about that at the federal level. I think it would be a state-specific decision about how they structure their relationships between their schools and their managed care contracts. But it's a great question because right now 3/4 of our beneficiaries are being served through managed care plans. And that's another thing just to take a little bit of a step back to think about. And I saw that you have a number of plan participants today to really make EPSDT generally work well for any screening services. Having approaches to manage care contracts between the state and the plan is really key. A lot depends, right? The contract is what a state legally holds the performance of the plan to. So that's really where kind of I think the rubber meets the road in terms of making sure kids get their services through managed care.
Well, if we can identify states that have moved this process along, I think that would be helpful to everyone.
Yep.
That'd be great.
Question over here.
Can I ask people to identify themselves as they ask questions?
Thank you for your remarks. My name is Miguelina Hedemang. I'm from Montefiore Medical Center in the Bronx. I wondered if you could speak about value-based payment. Our medical center is moving toward that model and away from fee-for-service, and I was just curious if you had any wisdom to share with us.
Sure.
Medical
I
centers are
would
trying to
bet
move
that
toward
Jason will have a lot of wisdom on this topic later today. But I'll say we strongly support the efforts that states and providers are making under a number of auspices and authorities of moving towards value-based payment. New York was an early leader through its DSRIP, and we're excited to see the progress. I think there's a lot that can be done in terms of value-based payment, particularly for children. You could do incentive payments for providers who deliver the right amounts of screening. You could do incentive payments for lead screening. When we launch our oral health section of our Innovation Accelerator program, we'll be focusing specifically on payment strategies. And we're also going to launch an initiative in technical support to states around maternal and infant health. As we move towards value-based payment, a lot of times the interest and energy is driven by Medicare, which is great that they're moving in that direction, but that's a very different population. And so taking on the topic of how we promote value-based payment for kids would be a very fruitful endeavor for the larger child health community.
Yes, I think it's been an easier sell on the adult side and a much harder, I think it's been much harder to sell it on the pediatric side. And I just wanted to make sure if the audience, if everyone understands what value-based payment is, or did anyone want to have a little more explanation on that? I yield that to you.
Sure. It's actually a pretty simple a concept. So historically, healthcare payments, and this isn't just Medicaid, this is throughout the healthcare system, have been paid on fee-for-service, pay-for-volume basis. Value-based purchasing is an umbrella under which providers and states can use strategies to pay for particular outcomes. So you could pay for a certain quality score, you could pay for a certain level of service delivery being provided. And so you've probably heard in the papers a lot of focus on this issue recently because CMS just launched a quality payment program for Medicare, which also ties some payments to other payers. And we've seen a lot of progress at the state level moving towards value-based payment. We, earlier this year, rewrote our managed care regulations, which hadn't been updated in more than 10 years. And one key area of focus for us was explicitly giving states the authority to do more value-based payment through their managed care plans, since that is how most states are delivering their Medicaid services. So there's a lot of groundwork that's been laid for doing more VBP. I think, and my guess is that if the larger kids' health community really dedicated themselves to thinking and talking about value-based purchasing for kids, you could get a lot of traction with states and providers.
Thank you so much.